Hi everyone, I want to talk to you about migraine. Risk factors here could be hereditary. Majority of people with migraine will have positive family history. In fact, before you ask them, they can even furnish you with that information voluntarily. But you can find out. Mostly hereditary. And if you are affected, you need to find out from your parent about the history in the family. It is commoner in females than in males. About 3 to 1 more females are affected than males. And other environmental factors that could play roles will be stress, insomnia, depression, increased weight, menstruation, and so on. So watch out for triggers and avoid them. You can conveniently say that it is both genetic and environmental problem. How do we prevent migraine headache? First thing is to know the triggers. And when you've done that, next thing is avoid them or devise the way to cope with them. It's also possible to have transcutaneous supraorbital nerve stimulation. Acupuncture is also welcome, and you can use cytomigran, riboflavin, simvastatin with vitamin D. Naproxen, that is non-steroidal anti-inflammatory drug, Allodynia at low dosage, about 2 to 3 milligrams per hour. Can also prevent migraine headache with some new manufactured medications like gacanizumab and erenumab. Gabapentin has been around for a while. Lamfaxine, valproate, the anticonvulsant valproate could not be given to a woman of childbearing age. Why? Because of terrible teratogenicity. It will affect the unborn baby. The pyramid is fine for obese people and anyone with epilepsy. You can also use angiotensin converting enzyme inhibitor like lisinopril or angiotensin receptor blocker like candesartan. Amitriptyline or nortriptyline if an elderly person, nortriptyline is better. Amitriptyline for the rest if there is also an associated insomnia. You can use dozepine. Flunarizine is a calcium channel blocker just as verapamil. But we have a lot of beta blockers to choose from. Tanolol, metoprolol, propranolol, nadolol. While using some of these heart-related or medications that could affect the blood pressure and the heart rate, we need to monitor those two parameters. That is, when you are using lisinopril, candesartan, calcium channel blockers, and beta blockers, please make sure you report to your doctor periodically to know your vital signs, particularly the blood pressure and the heart rate. They're going to titrate the medication based on the parameters. Still, on how to prevent migraine, you can adjust your lifestyle. Stop stressing yourself like someone who doesn't have migraine can freely do. You can't do just like the other set of human beings without migraine. So have a good sleep, get routine meals and schedules. Let there be regular exercise. And if all those will not work well for you, there is the third line agent like feverfew, tizanidine, emantine, pregabalin, ralheptidine, and zonisamide. You can choose any of these. Oh, I mean your doctor and you can decide to pick any of these. Okay, you've tried everything to prevent migraine, but you're not winning. Eventually, you've come down with acute migraine, migraine attack. Now you are in emergency room. There, you might be given sumatriptan 6 milligrams subcutaneously, and that could be repeated within the next 1 to 2 hours. Because many people with migraine will be vomiting, you can give you metoclopramide about 10 milligrams intravenously. Dihydroergotamine 1 milligram, ketorolac 30 milligram, all could be given intravenously, or ketorolac could be given intramuscularly in emergency room, just to make sure that pain is aborted quickly and vomiting is suppressed. If it is mild to moderate, then you have ample time, your physician has ample time to choose from non-steroidal anti-inflammatory medications like aspirin, depending on whether you have peptic ulcer disease or ongoing bleeding. Then you can choose from, or allergy, you can choose from aspirin, naproxen, ibuprofen, diclofenac, and the list goes on anyway, or acetaminophen. As a matter of fact, some will even combine the two, combine something like naproxen and acetaminophen, ibuprofen, and acetaminophen. Antiemetics, because vomiting is prominent in migraine, can have metoclopramide, haloperidol. Some will say, wow, haloperidol is for psychiatric people. Many medications are not used for one purpose alone. So chlorpromazine, some people will give it intravenously as well, but I've limited it to IM because it could shut down the blood pressure very fast. Prochlorperazine intravenously or intramuscularly. When you give all these antipsychotic, including metoclopramide, that you may not think it's antipsychotic, but then has extrapyramidal side effects, you might want to give Benadryl to assist along that. To decrease it. The triptans here could be sumatriptan given subcutaneously or per oral or intranasal. Sumatriptan, rizatriptan, elatriptan, an enzyme inhibitor will increase the effects. Also, amitriptan. Amitriptan is best used in younger age people. Ergots are also useful, but dihydroergotamine DHA45 is preferred. Ergotamine titrate should not be used here, and you can ask why that. It increases the nausea and vomiting that someone suffering from migraine will already present with, so making it worse. Also, if the headache is aborted, if at all, then it can rebound. And when you're on it for a long time, you come down with valvular heart disease. So we have two examples here, but one is preferred and the other one should be run away from. Dihydroergotamine is okay. Ergotamine tartrate should not be used. Dexamethasone and surgery. Yes, dexamethasone intravenously or intramuscularly. Your doctor will guide you as per the dosage, and surgery could also come in if everything is not working, like vagus stimulation and supraorbital nerve stimulation will be done. What are the clinical features of migraine? Often it will be unilateral, but not always. In other words, in majority of people and most of the times in the individual affected, the pain will be unilateral. But that is not to say if it is not unilateral, it is not migraine. No, there's nothing called that. So often it could be unilateral, but not always. Pain could be throbbing or pulsating, associated with nausea and vomiting. Photophobia, that is, they hate or they're afraid of light. Or phonophobia, or both. Phonophobia is they're afraid or they hate sound. And that is why when you tell people suffering from migraine to go and lay down in the dark because of the light and quiet because of phonophobia, then they have some level of relief. Okay, phonophobia or photophobia could be addressed by telling the patient to go and rest in a dark and quiet room. Osmophobia, that is odor aversion, is also possible in them, and some might take offense, but please don't. That is part of clinical features of migraine. Allodynia, that is cutaneous allodynia. This time they feel pain from the stimulus that ordinarily wouldn't have given pain. So they feel pain when scalp is touched, like while combing the hair or creaming or doing anything, they feel pain. They feel pain when they are shaving or when they are resting on the affected side. I mean, when they are laying down on the affected side, like laying down on the left side on the bed or on any object like desk or anywhere, they feel pain on that affected side the more. Bacillary type of migraine will present with vertigo, ataxia, and dysarthria, while visual aura will be positive if the patient complains of zigzag lines and flickering lines. If he or she says it is scotoma, then it is negative. Sensory aura is positive when it is pains and needles, and is negative when it is numbness. That's what we call hemiplegic migraine. The aura here is in form of motor weakness, associated with visual field defects, scintillating scotoma, numbness, paresthesia, aphasia, fever, lethargy, seizures, and coma. Also, an individual with migraine could present with retinal migraine. In that case, there will be transient blindness, but they will recover from that. Vestibular migraine will present with vertigo, tell you that everything around them is spinning. And menstrual migraine, of course, I don't need to say that that is in women, but let me just say on record right now that menstrual migraine will affect women of childbearing age who are menstruating because it will be worse during menstrual periods alone. It could be atypical in presentation. When it is atypical, it means it is without aura, and that could last for 4 to 72 hours. But before you make a full diagnosis, please make sure no other cause of headache is present here. And ask about history of photophobia, of fear of light, and phonophobia, fear of sound. That's the reason why you might prescribe resting in a quiet and dark room. History of nausea and vomiting here, mostly unilateral and pulsating. There will be decreasing routine life activities. Please, when you have any young woman or man working at your place of work and they come down with migraine, they tell you, I can't do anything right now. They sit down, they're not talking, they're vomiting and holding one side of the head. Please, they are not making it up. They are not pretending. It can decrease routine life activities, going out, having fun, working, and so on and so forth. Migraine could be typical or known to be with aura. The aura could be in form of vision, seeing stuff that the rest could not see, sensory, speech, language, motor, retina, or brainstem. At least when it is typical, that means when it is with aura, they will have at least one aura over 5 minutes. And they can have 2 or more symptoms, one after the other. The symptoms may last between 5 to 60 minutes, and that will be followed by the headache. And you may be thinking of differential diagnosis here to be TIA, that is transient ischemic attack. As a matter of fact, many people with migraine want to rule out transient ischemic attack. And people who present with transient ischemic attack will ask about the history of migraine in them. And cluster headache, I will talk more about cluster headache in another presentation, and tension type headache. You will do CT scan if you are suspecting HIV or AIDS. And if this individual is presenting with the first headache in his or her life at the age of 50 and above, you might want to do CT scan here to be comfortable. If this individual has been diagnosed with cancer, you want to rule out metastasis to the brain. And is this meningitis, any associated fever, neck stiffness, and the like? You want to do lumbar puncture also if you are suspecting meningitis. And if this individual has been presenting with the same unilateral side all the time, you want to be sure it is truly migraine and not something else in the brain. If the frequency is increasing or the severity is increasing, then calling for CT scan will be fine to be sure there is nothing increasing the intracranial pressure here. And the first thing, or the headache, is the first headache of his or her life, regardless of the age, and you're not sure it is migraine, first visit you might want to do CT scan. Now, If the individual says, this is the worst headache of my life, then you are suspecting subarachnoid hemorrhage, or there is even history of trauma, but you don't even need the history of trauma before someone could have subarachnoid hemorrhage. In that case, you want to be, assuring yourself and assuring the patient, just do CT scan. And if it comes down to be subarachnoid hemorrhage, know the next thing to do, call the neurosurgeon. Neurological impairment is picked on physical examination. You might want to do CT scan to be sure. And you've done everything that you could do for my sister who has had migraine. You've given preventive measures, but you're not winning. She has come down with acute state. You've given everything that you should give. You're not winning. Now, you want to try to be sure that you are truly dealing with only migraine, then you do CT scan. In conclusion, thorough history and examination will lead to accurate diagnosis. And accurate diagnosis will lead to appropriate treatment. And when appropriate treatment is embarked upon, we both have good outcome. That is, both caregiver and the recipient, the patient. Thank you for listening to my presentation. Kindly subscribe so that you can get these presentations immediately they are published. Thank you.